one. Before we do, are there any pressing questions that you guys did shout out into the Facebook group that we have logged down and are going to skip our way through? We've got about 10 of them pulled up, but if there's one right now that someone wants to shout out live, we'll take that first as a starter. Squat science was the topic this week, and back squat was the movement this week.
I'll start with a little announcement. We're basically destroying this class from the ground up while you're taking it. So if you look back on week one, it's going to look entirely different. We're re-recording all the lectures, redoing all the case studies. So if you happen to look back into weeks after we've gone through them, you'll notice they look different. It's fine. That won't change anything as far as what's on the exams or anything like that. But if you happen to look past weeks, it will look a lot different, and that's because we're redoing it week by week as you all go through it, so that it's ready to be relaunched in 2021. Is a not different course, but certainly looking a lot better and having updated 2020 content in it.
Well, hearing none, seeing none, we don't have time to waste. So let's take the first one here. Queued up first on our list. How common is it to find an athlete that is squatting with a certain stance width or a toed out combo that is not ideal? And then a second part there is, when experimenting with change, what does clinical reasoning process look like? And Alan, Guillermo, and I are very comfortable in the gray in a lot of areas, but this is one of them. And meaning, we usually have somebody literally stand in front of us and we play around with a lot of different foot stance positions. We, as a profession, and this is going to be a hard one for us to it's taken a lot of years and it's going to continue to take a lot of years. We have to get comfortable with humans being asymmetrical. This idea that we were all printed and stamped out square and equal and level and plumb and true is simply not human nature. You, like, the more data that comes out about MRI, X-ray, putting people through the tube, we know abnormal findings are way more common than quote unquote normal findings in all things. So using symmetry and balance and level is not something that guides our clinical reasoning. What guides our clinical reasoning is efficiency of the movement, right? And looking at those points of performance that we've mapped out, and also symptoms, right? Like, if people are coming to see us, we want to evaluate their movement and what's causing symptoms. And if I modify their position and it reduces or eliminates entirely their symptoms, then that's a good correction, right? So in regards to stance foot width position, for example, Alan squats narrow with his feet and pretty turned out, right? And that's due to his negative amount of ankle dorsiflexion, but a pretty solid amount of hip external rotation that allows him to drive his knees out to the side and still reach depth. I have nil amount of dorsiflexion. It's not awesome, but it's not great by any of the means. But I have a lot of hip mobility, and I choose to go with a little bit more wider, a little bit more toe forward. It's not perfectly 0 degrees toe forward in neutral. Our training partner Jamie has a fused right ankle, and she's going to kick that ankle forward and off to the side out in front of her. That one a little bit more externally rotated, and that's her squat position. It's the position that she's learned since she started CrossFit. She's always squatted in that pattern, right? So her asymmetries are a little bit more glaring than Alan and I's asymmetries, right? And so, in short, we're comfortable with making individual tweaks based on the patient presentation in front of us. Do we say, as a sweeping statement, that the feet should be balanced and neutral, 0 to 10 degrees toed out for most folks? Yes, because people want buoys. They want like a lane to stay in for the most part. But you have to understand that each individual that you come in contact with may not fit that line. And we have to be able to use our clinical judgment and say, this is still a solid squat. It meets all the other points of performance. They don't have pain or symptoms with it. And to accommodate one, maybe they got one retroverted hip that feels a little bit better when they externally rotate it slightly. I'll oftentimes If that's the case, I'll try to match it with the other one. But let's be honest, that may not feel comfortable on the left hip to match the external rotation that's on the retroverted hip, right? So like, I'll try to get symmetry out of it. And if I can't, I'll say, you know what? This foot likes to be a little bit more neutral. This foot likes to be a little bit more toed out. It is what it is. Let's maintain our knee position relative to our ankle and our foot. Let's try to get hip crease below the knee, all those sorts of things. So to that line, are we very hard line of like the feet need to be here? Absolutely not, because we appreciate the asymmetry between human beings and every individual that comes in contact with you. And we know the points of performance that we want to maintain, and we're going to do what's necessary to be able to meet most of those. Alan, anything to add on top?
No, just, there's an argument that if you're so toed out and so wide, you're going to be putting maximal stretch on your external rotators, primarily your glutes, and you're not going to have a lot of torque to drive out of the squat. Likewise, we talked last week about the importance of internal rotation. If you only leverage external rotation, you're going to be pulling the head of that femur anterior in the socket, and that can be symptomatic for some people. If it's not, great, but it can be the cause of symptoms in folks. That femur head is all the way forward with not a lot of internal rotation standing up out of the squat to pull it back center or even some posterior. But if that person is still gaining strength, yes, they can benefit from some more internal rotation. That's going to let them get maybe a little bit more narrow or neutral stance and a little bit more toed in. But that's kind of stuff you're working on while you're still squatting regularly. You don't pull somebody away from the squat unless it's extremely symptomatic. So adjusting their stance, giving them stuff to work on, but primarily doing what you can to keep them squatting, adjusting their stance, elevating their heels, whatever it is to get them to continue to squat regularly. That's probably the most important thing you can do for that person.
Kind of along that vein, and I want to skip a couple questions that we've got here. Along that vein, we see a question. I want to find it. Here we go. Movement faults, including asymmetrical hip height or lateral pelvic shift when someone squats. What's our hypothesis about what may be going on and how do we address it? Again, hip height, kind of just along that same vein, appreciating the asymmetry there. We could go down to the research rabbit hole of being able to diagnose or how clinically relevant leg length discrepancies are, true versus, positional. More than anything, that lateral pelvic shift, right? If we're seeing a dynamic movement fault of a lateral pelvic shift while initiating or coming out of the hole of the squat, what's going on with that? In my book, it's one of two reasons. One, they're shifting away from pain or into more mobility. Right. So I've got pain on my right side. And as I'm sitting down into the squat, I'm trying to, my organism's natural response is to get out of pain. So you may see individuals shift to the left and away from that right hip. You may also see individuals sitting down and the right hip is stiffer than the left hip, and they'll continue to sit into that left hip more. So they're shifting away from an immobility, away from pain into a hip with more mobility. Right. Do I know if that's conclusive? Is that all the reasons why someone may have a lateral shift? No, they may have some back symptoms going on that we need to clear out, lateral shift type dysfunction from that standpoint. But for me, those are my two questions I'm usually asking myself. So one's easy. Are you having pain with squatting? Yes or no? Yeah. As I reach the bottom, I'm starting to feel some stuff going on. Yeah. Is it my hip? Is it my back? Is it down my leg? And then two is if they're not having pain, then a quick hip screen should do the trick, or an ankle screen should do the trick, determining if they're running out of mobility somewhere. If both of those answers are no pain, no immobility, then the question is of like, is this just a motor control or neurological pattern that this athlete doesn't even know they're doing, right? And so this may be like think post-op ACL, right? Like 2 years post-op ACL, they're shifting down into the left and they don't even know that that's their natural positional routine, right? Or you guys have seen this for many different cases. I don't need to give more examples, but that may be the case, right? No mobility dysfunction, no pain with the squat. This is just motor control that we need to rewire and repattern. I saw some chat stuff. Oh, perfect timing. Hip injury, motor control, several months to struggle. Nice, Guillermo. Anything else to add on top of that, Gmo or Fred?
I currently do not. No.
Thank you very much.
I'll grab question 2 here. Can you give examples of squat demands and mechanics and how they differ from a CrossFit athlete compared to powerlifters? Yes. And then low bar versus high bar, any studies to look at the difference in the 2 bar positions has in the body? Yes, plenty. Provide the anatomical landmarks on the body for bar placement. So instead of that, we're going to watch a video. Share my screen here really quickly. We'll watch a video first and then we'll talk after. So this is a gal, I have no idea who this is, but this is a low bar back squat. So the bar is going to start much lower, kind of mid scapular area off the traps. We stay posterior shifted the entire time to keep the barbell on our back. We sit down, we're aiming for parallel and no deeper. I'll play it again. I don't know what's happening there. So the bar placement is different. It's lower. It's going to shift us back. It's primarily a hip hinge. And then standing up out of the bottom, we primarily leverage the posterior chain. Glutes, hamstrings, low back. Much more forward torso. We're trying to leverage getting to parallel and no deeper as efficiently as possible. So we see this very often in powerlifting, where the goal is to get to parallel and stand up, and that's a completed rep. So in CrossFit, we do not low bar back squat. And the reason is because a high bar back squat, the back squat that we had you all show us this week, transfers a lot more skill wise to a lot of different movements in CrossFit. Wall balls, thrusters, cleans, snatches require an upright torso. And so training the high bar back squat gets you comfortable squatting with an upright torso. And so if you're treating CrossFitters, you are a CrossFitter, it's important that you're high bar back squatting. Yes, you're not going to be able to squat as much, but it transfers into a lot more squat patterns than a low bar. The EMG difference is you're going to leverage more posterior chain with the low bar back squat. Clinically, what you'll meet is a lot of people who are low bar back squatting just to say that they squat and get strong legs, who are squatting through low back pain, hip impingement, a lot of different issues caused by a low bar back squat, or otherwise essentially a good morning squat, leveraging only the posterior chain. And so the question for those folks is, what are your training goals? Do you want to be a power lifter? Do you want to be a competitive power lifter? Do you want to train for a meet? If so, we need to keep grooving the low bar back squat. We need to find a way to calm your symptoms down and keep you low bar back squatting. But if you're a CrossFitter, you need to be high bar back squatting for the skill transference. And if you're just somebody squatting because you know squats make your legs stronger, then let's consider the high bar back squat, especially if you're currently having symptoms with the low bar. Maybe get you back to low bar if you really want that as a goal, but otherwise offload the hips and low back a little bit with the high bar and get you high bar back squatting and take some of those symptoms off the table. Questions on low bar versus high bar? I mainly want to know if Anna and Nick are in the same house, but on different computers. That's amazing.
We definitely are.
Okay. I wanted to ask last week, but I forgot. Okay, I'll grab number 4 here too, since we're on the topic of EMG. If the difference between back squat and front squat EMG findings are the same, how do we explain the differences in squat difference? So you're only going to be able to front squat about 80% of your back squat max. Why is that? If the muscle use is primarily the same, what's the difference? Well, the difference is the rack position. Back squat is much more stable. The bar is literally over your spine. It's stacked. You're going to be able to lift a lot more weight because of where it is on your body, versus when we bring in the front rack position, we now need thoracic spine, not only mobility, but strength as well. And so that's the limiting factor as to why you'll never be able to front squat as much as you can back squat. If you're more comfortable in a front squat than a back squat, it means we need to look at your back squat mechanics. If you're that person, we need to look at what's going on with your back squat, that your numbers are so close together. Otherwise, they should always be 80% front squat or back squat. And it comes down to T-spine strength. Any questions on that? Beautiful.
If you want proof of this concept, just watch any heavy front squat video of mine and you'll clearly see the weakness exposed.
Mitch, you want to grab the next two?
Number 5 and 6.
Yep. How do I get my calves to grow half the size of Alan's? Good question. Mine are an eighth of the size of Alan's and still not growing. So I am the wrong person to answer this. Alan always says, can I say what you always say?
Yeah.
Alan always says, grow to 400 pounds, carry that weight around with you for the better part of a decade, and then shed the weight and your calves will be bigger. Did I get it right?
Yeah. I don't do anything for my calves.
You what?
I don't do anything for my calves.
He doesn't do a thing for his calves. His calves are actually crazy weak. It's surprising.
He's all soleus.
He asked me to treat his calves often. So no answers to that. Just a calf hypertrophy program that Zach Long continues to try to pioneer, and I'm sure it will be on Performance Plus if he does. Bonnie's questions highlighted. Fred, did you already grab that?
No, I highlighted it because you're gonna grab it.
Okay, so you're ahead of me. Bonnie says, are there common corrections that you end up applying to tall athletes and or those with proportionately long femurs? Yes, and I'm so glad you asked this question. As a general statement of the athletes that I've worked with, individuals with long femurs and long legs are naturally going to prefer a wider, more toed out, more externally rotated squat than normal. To the point where like they set up and you're going to look at them as a novice coach and say, your feet are too wide, bring your feet in. Because I was told that squats are supposed to be shoulder width apart. But hold the phone. Why is that the case? That femur is so long in the sagittal plane, going towards my camera here, if you guys can get that when we externally rotate it, then it gets a little bit shorter in that sagittal plane. And when that femur gets shorter in that sagittal plane, that means my torso doesn't have to lean over that long femur so far. I can shorten that femur and my torso can come upright a little bit more. I hope you are getting the depth concept with all this hand direction. So by externally rotating, we theoretically shorten the femur in the sagittal plane, which allows the torso to come upright a little bit more, which allows individuals to not feel the quote unquote tightness or pinchiness in the hip that they often report, how much relative hip flexion has to be on board when the torso has to lay forward over that long femur. We shortened it and therefore the torso comes upright. So they end up sitting deeper into their squat, more upright in their squat, and less butt wink or lumbar reversal in their squat. So again, for longer legged athletes relative to their torso length in long femurs, they tend to prefer a little bit wider toed out stance. Is that always the case? No. I've seen some athletes with really long femurs and also like a ridiculous amount of dorsiflexion where their knee can shoot like feet past their toes. And they're able to squat with like a neutral stance, bottom it out, and have no faults at all. So I'm not saying that every individual has to squat that. Prefer a majority of athletes, they may prefer that better. Alan, I'm going to ask you the next question.
Great.
Your personal strategies for dealing with patients who are unable to tolerate a squat due to patellar tendonitis, tendinopathy, anterior knee pain. What do you got?
Yeah, and we're kind of jumping ahead. Week 4, we're going to talk about the symptom behavior model, which is hopefully how you're all going to practice, evaluate, treat, reassess a patient after this course if you're not already. But the answer to number 7 is going to depend wildly on their symptom behavior. It's also not really important depending on what tolerate means. If it's painful, I'm okay, up to a 5 to 7 out of 10 pain, especially if it is a true tendinopathy. What the literature shows us is we drastically underload tendinopathies. We don't push people into pain. If it's a tendinopathy, it should hurt a little bit during exercise and it should hurt a little bit after, and then it should feel better the next day or the day after that. And we should be exercising in pain with these patients up to a 5 to 7 out of 10 pain. And we should be getting a lot of tension into that tendon. And so I'm going to find a variation where that person is in a 3 to 5 out of 10 pain. If that's a squat, that's okay. If a squat is too much for that person, maybe it's something like isometrics or knee extensor or eccentrics or something like that until they can tolerate a squat. But ideally finding a squat variation to load that tendon and being fine with it being painful. I love to give these folks Spanish squat eccentrics with the kettlebell. get a lot of time under tension. You need to be getting minutes and minutes and minutes time under tension into that tendon, aiming for over 220 seconds per exercise, which is a couple minutes of tension. So just giving this person 3x10 air squats isn't going to cut it. We need to be getting a lot of tension in that tendon, and we need to be comfortable that it's a little bit painful. And so finding a variation, it might be reduced range of motion, that's okay. But finding a variation of a squat or another way to load those legs and load that tendon is what I'm going to get after. We don't have any names here, so if you ask this question and you want to wrap some more about that, feel free to speak up.
I actually had a follow-on question. You talk about eccentrics, and I'm just kind of thinking back to sort of earlier in practice and some of the older school physios doing a lot of like the eccentric protocols, but the fast ones, you know, like the drops and the quarter squat drops and all that stuff. And I've never in my life had any success with that. So I abandoned it a very long time ago. So if I do eccentrics, it's slow, like negatives. Just wondering if, because according to the most recent thing I've seen in the literature, it still holds true that the like high volume of those fast eccentrics is still sort of best practice. Just wondering you guys' thoughts on that.
Yeah, so some of the literature coming out, you know, there was that argument, is it heavy, slow load? Is it the long time under tension? Is it the load? Is it the tension? And the answer is we don't really know yet. There's great literature supporting both. There's awesome literature in the shoulder of 15-second negatives, which is terrible, but under really low load, a couple pounds of weight for negatives for rotator cuff tendinopathy. So it's the question of, is it the long time under tension? Is it getting to, you know, minutes and minutes of time under tension, or is it the heavy load at a slower tempo, or both? And to me, it's a matter of what is the patient going to tolerate symptom-wise. And it's really important with these patients that we're monitoring 24-hour follow-up, that we're sending them a text the next morning and finding out, are you better? Are you worse? Are you the same? You know, are you twice as painful? Do you have no pain? And knowing if they wake up day after day and they're in a lot worse pain, we're probably overdoing it. And if they wake up day after day and they feel no different, we're probably underdoing it, and trying to find, by monitoring their symptom of whatever we're using that they can tolerate and tracking that over time. I tend to go with some combination of both, of trying to get heavy load and time under tension. In my mind, with the tendinopathy patient, I'm always shooting for the Joe Cook number of 220 seconds, trying to get about 4 minutes time under tension into that tendon.
All at once, too. One set, 4 minutes.
Yeah, a 220-second negative.
Very slow moving negative. Okay, so the next question I want to tackle is bracing. And a lot of people kind of, maybe I left some comments on some of your videos that, hey, a little bit of bracing would help clean up some of the butt wink that we're seeing here. And these next two questions, I guess, go hand in hand, talking about bracing and the butt wink. And so a lot of people had the question of like, I'm interested to hear more about bracing. How does it help stabilize the spine? You know, maybe I'm not tracking well. So let's just tackle the bracing thing for a minute. A lot of people think bracing is just like drawing their belly in, or like sucking their abs in, or maybe flexing their abdominal wall hard, right? True bracing for the squat is much more complex than that. We're really trying to, we're viewing it as a Miller Lite. We're viewing the intra-abdominal cavity as a cylinder, right? And we want to fill and seal that cylinder to make that really rigid and robust against axial compressive forces. Just flexing the front of the abdomen and crunching down doesn't make this cylinder any stronger, right? In fact, it may kink the system and theoretically make it weaker. So what we're trying to do when we breathe and brace, and in powerlifting coaches will say 360 degrees of pressure outward against the abdominal wall. So like from inside the cup, pushing outward against the abdominal wall in all 360 degrees. What I try to think about is very simple. If you had a belt on, you could put it on, but if not, just take your hands and put them around your waist, around about your belly button, just above your hips, and take a belly breath in. And when you breathe in the belly, try to push out against your hands through your abdominal wall. That's breathing in, using the diaphragm, drawing breath in and pushing out. Now we're going to pressurize that cylinder basically by bracing. So I breathe in and then I prepare to leave a punch. So breathe in, and then get tight for a punch. what some of you are noticing is that created a lot of pressure against your fingers. And that's exactly what we want. We pressurized the cylinder and then we got it tight and we're stabilizing all the small vertebrae that are stacked upon one another. Those are now wrapped in this pressurized cylinder that's sealed and strong. Some of you may also be thinking, Mitch, that sounds like bull crap because I work with a lot of pelvic floor patients with pelvic floor dysfunction, and a Valsalva maneuver is symptomatic, and we don't want to do that. And you're absolutely right with that patient population, right? So being mindful that bracing, how to cue and utilize bracings for max performance for patients without pelvic floor dysfunction is different for patients with pelvic floor dysfunction. Okay. It's and not or. It's not, well, that bracing sequence must be faulty because for this patient population, it doesn't work. For that patient population that are having pelvic floor dysfunction, we utilize a blow as you go strategy. And many of you are familiar with this. This is going to be like a pressurized exhale, or what I think of like blowing out through a straw on the way up in the squat. So on the way down, I'm either breathing in or I've already breathed in and I'm holding that pressure. And then when I go to contract and push out, I'm letting like a slow pressure release off. That way the bearing down the Valsalva isn't down on my pelvic floor, but it's got an escape valve. Breathing out as we stand up, right? Pelvic floor dysfunction patients versus max bracing technique efficiency under heavy loads, max performance, right? Bracing in the literature is shown to help increase a 1 rep max. Utilizing a belt is also shown to help increase a 1 rep max. So when we cue and utilize the brace, that's what we're trying to go after, is stabilizing the spine with the use of pressure and breath control to help make the midline stronger, to help lock everything into more of a neutral position that doesn't change shape. Now, for some of you, that those minor wiggle rooms of butt wink that you're seeing in your video will get cleaned up when you just pressurize the midline a little bit more. When you just add a little bit of a bracing sequence in there, that little bit of lumbar reversal or hyperextension that you may be seeing will oftentimes clear away, right? And this is why we see some people under really light loads show some movement faults of like the butt wink, and then they naturally put a heavier weight on their back and they don't even realize their natural bracing sequence. Their body is already upregulating some stability and that butt wink disappears, right? So that what's common for us to see that, but it's also common for people to weight train for a long time and have no clue how to effectively breathe and brace, right? They literally they hear brace your midline all the time and they think it's just a crunch. They just think of it as doing a little mini sit-up or something while they're squatting. And that's not ideal, especially when we've got a few 100 pounds on our back that would like for us to go into flexion so that it can win. And we're trying to maintain upright posture, right? So along that vein, the butt wink, okay, so let's say we breathe and brace and we still don't clean up some of that butt wink. How would I cue or correct it, right? Assuming that butt wink, assuming that the bracing is on point, we get to the bottom and I start to see a little bit of lumbar reversal at the bottom of the squat. We got a couple of videos that will showcase this tonight. What do we cue and facilitate? Well, the first thing I like to do, and I know Alan and Guillermo do the same thing, is go with some tempo work. Right? Like let's slow the athlete down, and I'm going to pause the athlete when they begin to demonstrate that lumbar reversal, when they start to move from a neutral position and they're starting to take the lumbar spine into flexion. So I'm going to say squat really slow and pause right there. Can you feel your low back start to tuck under? I want you to drive your chest up proud for me, and that's going to upregulate erector strength. So ideally we'll pull them into a little bit more of that neutral position again. And if they recorrect that position, I'll say, good, 1 inch lower now. And so I have them to pull themselves down a little bit lower. Again, chest up hard for me. I may also say, hey, drive your knees forward, because they may be getting to a point where their hips are too far back, causing that butt wink. I want them to drive their knees forward and pulling their butt to their heels. Those are a few cues that I may give. If it's happening at too far of an end range, then maybe we give them a target to sit to, a med ball or a 12-inch box that they can slowly touch and then come back up. But ultimately, that tempo with that little bit of facilitation on the lumbar spine and a little bit of cueing about driving the chest up and driving the knees out can oftentimes clear out a majority of that butt wink that's going on. How are we doing with those two? Those were two big ones. totally unplanned visual aid. Yep, that's why I had this here. You'll never forget about a breathing and bracing concept.
Nick has a good question. When to advise an athlete to use a belt? I find some people get a little too reliant on using the belt even at lower loads. So personally myself, I only use a belt when I know it's going to be very high volume or if it's going to be very heavy, somewhere above 85% of my max, or if I'm trying to set a new max. If it's below that, if it's training, we're training at 70%, 75% of our max, I'm not using a belt. You saw me slap a belt on my video, but that was quite close to my max under a lot of fatigue. You have some folks that wear a belt all the time in the gym. You have folks wearing a belt doing bicep curls, right? You've seen those people in the Globo gym. You're like, what the hell is that guy doing? And so it's important to have that conversation of like, why are you wearing that belt? I have that question a lot, especially on heavy lifting days with our athletes of like, you know, we're just getting started, or I know the stimulus for the day is not a max out. I know we're doing 5x5 max squat at 75%. Why are you wearing a belt? And if you have those questions, you'll get the answer often if that person is having pain or they're having symptoms, they're having pelvic floor symptoms. See that a lot with a lot of the ladies in the gym having symptoms with a belt on. Belts don't fix backs. Yeah. So having that conversation, why are you wearing that? Oh, well, back squats always hurt my back, or deadlifts always hurt my back, so I always wear a belt. Or I always pee my pants when I squat, so I put this belt on. And that's a really good time to have that conversation about how to breathe and brace in the movement that we're doing. It's something I talk about now every time we coach heavy lifting. I always take a few seconds to talk about breathing and bracing. There's always somebody who benefits from that. A lot of folks just bear down in the gym. Ladies pee their pants, guys cut a huge fart because they're just bearing down. They have no idea how to breathe and brace their spine. Good. Let's move on. Got a couple more here. Amanda, I'm going to take part of yours, and part of yours is going to be answered by an answer to another question. So Amanda says, many of my patients demonstrate navicular drop with squatting, causing valgus, anterior internal rotation. Do you recommend orthotics in addition to arch strengthening or raising exercises? I struggle with wanting to correct their foot position and stability prior to progressing squats. I pretty much never recommend an orthotic. I don't know that I've ever recommended an orthotic. It'd be hard to see navicular drop with shoes on. And I also want to know what have you ruled out in the hip or back, which may be contributing to valgus before we go to navicular drop and start posting people's feet and stuff. We know from the literature, posting people up is not a long-term solution or fix. When I see valgus, especially unilateral, especially symptomatic, I go to what's going on in the hip that we cannot pull our knee out of valgus, and then go from there. There's some other stuff we can clear up in the midfoot. We can see what's going on with things like the table test, looking at dorsiflexion, looking at lateral tibial glide. Can they actually drive their knee outside of their foot when we have them up on the table in 90-90, and trying to figure out what's going on the midfoot and or the hip that's contributing to what we see at the knee. And I've never had to post anybody's foot or anything like that. Second question here about chondromalacia, clicking, grinding, and squatting with pain. And what to do to avoid that, to avoid increasing knee pain. And I'm actually going to jump down to Megan's question. Megan asks, Hartman article talks about heavy loaded quarter squats is an appropriate loading exercise for those with patellofemoral symptoms. Deep squats result in increased patellofemoral forces, especially in females. Thoughts on this in lieu of the conversation or focus on recommendations for deep squats? Yes. So it's important to know, yes, the force gets greater as we squat deeper, and it's the highest at about 90 to 95 degrees. Now, it's decreased below parallel, and yes, we have to go through the highest force point at the knee to get there, but we're usually not spending a lot of time there. Unless we're intentionally doing tempo, we're not hanging out in a quarter squat position or at parallel, we're dropping down and standing up. So we're moving through the hardest part quickly, and actually the most time under tension is standing back up from the bottom. A lot of this research is on powerlifters, and they're not squatting below parallel regularly. So it's hard to extrapolate what's going on in their knee to the general population, especially a population like CrossFitters who are high bar back squatting below depth on a regular basis. The literature on that we grab from Olympic weightlifting research. That's a lot of the research that we cite. And if we actually dig deeper into that article, we pull out some really good quotes. Recommendations cannot be extrapolated readily to encourage a quarterback squat because they do not take into account the influence of the reversal of motion, dropping down and standing up, or on different loads of a particular squat variant that can be tolerated. And so we know we can never lift as much in a deep squat as a quarter squat. You can lift 4 times your body weight in a quarter squat because you're going down this far. You'll never be able to do that for most of us in a deep squat. So we're not putting as much load through the squat as we would be on a quarter squat. So that's naturally going to reduce the force at the knee. Lower weight is used. Functional adaptations are found in deep squats, which lead to adaptations of passive tissue, and concerns, quote, concerns about degenerative changes of the tendofemoral complex are unfounded and unproven. Why? Because beyond 90 degrees, we have a cranial based displacement, contact areas enlarge, and we actually get less stress on the retropatellar articulating surface and actually an enlargement of that because it's cartilage based. When you load cartilage, it grows. And so that kind of wraps back into Amanda's question about folks who have clicking, grinding pain in the kneecap. We need to find a way to get them squatting through a deeper range of motion. If we only have them quarter squatting, we're having them squat through the force at the knee that's the highest. And they're always going to have issues with squatting. I think of all the patients in the past that I used to have hold on to the rail in the clinic and just do quarter squats, and all they did was just drive their knee forward. They never leveraged their hips, and they always complained about knee pain with squatting. And I always bailed on squatting with those patients because I didn't know any better. Instead of finding a way, using things like Spanish squats to offload their knee, squatting to a target, playing with things like goblet squats to get their chest up more and improve their torso angle to reduce the stress at the knee and have it be taken up by the hip and ankle a little bit more. So kind of 2 questions answered in one there.
What about athletes that have already had their meniscus taken out? How would we address that, especially if they believe deep squats are going to damage their knee even more? Sorry, Fred is typing.
Sorry.
I was reading you the follow-up question.
How would we address that, especially if they believe? Yeah, and so if the meniscus is gone, we still have the cartilage of the articulating surfaces. And again, cartilage is a load-bearing structure. It doesn't grow if we don't load it. And so we have to work with what we have left. We have to respect that the meniscus is gone, but we still have to find a way to load that surface. No different than if we've broken a bone. We can't just avoid loading because the bone has broken. We need to find a way to load around it, find ways that are tolerated well, and then continue to load to tolerance. And we do that with the symptom behavior model of
Yeah, I just keep in mind the fact that if we don't load, all those structures will get weaker. And what's the trade-off of not loading it and allowing everything to degrade? And we know that catabolic process is going to take place. That load-bearing structure, like the cartilage on the ends of the bone, are going to erode away when they're not loaded, or load to whatever symptoms allow me to do whatever weight I can do, whatever range of motion I can tolerate, and allow those structures to adapt over time and to stiffen and thicken over time with what's available to them. So I would rather take one that I know adaptation is going to take place rather than, degradation of the cartilage. Wid says, what goniometer app do you use on your phone? What's that Goni Pro app? Is that what it's called?
Goniometer Pro on iPhone.
An iPhone?
If you have
It's
an
super
Android,
handy.
Grow up, get with it.
Yeah, super handy. Pull it out, pop it on there, tap it, saves the measurement. It's great. You can document it. Let's get into some videos, man, because it's 8:40 and we've got a full 30 minutes of videos coming down the pipe. So we're going to show you in real time some of these butt winks and everything. If I know correctly, Guillermo has a bunch queued up and ready to fire at you guys tonight.
I do. Let's see.
Go ahead and minimize that child's video that you're playing up there. Little Disney show that you got up there on the screen.
It's the Wiggles.
The Wiggles.
Yes, yes.
Baby girl went to bed already.
Yeah, she's asleep already. I watch for fun.
Boy, am I jealous of her.
There. All right. Alrighty. Everyone can see that?
We got it.
Good. All right. So we're starting here with Jesse's video. And I think Jesse's group 3. So anterior view on the left, lateral view on the right. I'll start with the anterior view just so everyone can take a look at it. I'll play each one through once, and then I'm gonna have group 3. Just go ahead and jump in with any comments, what you guys saw from her videos that you saw that she could change, she could fix, improve upon, etc. I think this is around 185 pounds. I'm not 100% positive, but 195 maybe. I see a change blade on there.
$165, Jesse says.
165. Okay. Apologize for overestimating you. Solid lateral view. Go ahead. Anyone from group 3 or Jesse, if you guys want to jump in.
My self-critiques, I just think when I get fatigued, I think in those last couple of reps, I tend to lift more, like my hips lead the movement first, kind of like knees straighten rather than like knees and hips extending together. It's kind of what I'm noticing. Was something that stood out to me, and something that I noticed like while I was doing it, I kind of felt that happen. So that was one thing that I wanted to point out.
Anyone else in group 3 on? Anyone else see anything else? No takers.
I feel like to initiate the squat, her hips break first rather than the hips breaking back and the knees breaking forward at the same time. And then also she could use a stronger grip on the bar to get more of that trunk activated, and she'd probably get a lot more weight if she just gripped the bar harder.
Jesse, how long have you been doing CrossFit?
About 4 years or so. There was a hiatus because I had torn my ACL, so I took like 9 months off from when I first started.
Yeah.
So I would say cumulatively about 4 years.
So I asked that question because there was a time that a lot of us learned to squat around the same time, where it was initiate with the hips and then sit down. In what we've come to realize is that a lot of the best squatters, especially speaking to the Olympic lifting circuit more so than the powerlifting, you'll see them break hips and knees simultaneously. And that's where kind of like this new evolution of like, okay, maybe we didn't need to reach the hips and then sit down. And maybe what that did was caused us to already lean forward a bunch. So that your squat resembles what I had hardwired in my head as well, right? I need to bump these back just a couple inches and then go down. And now I'm more comfortable saying, just break hips and knees and sit straight down.
Sure. Yeah, definitely. Thank you so much for that feedback.
Yeah.
I would say the same. Go ahead, Bonnie. You're good.
I was going to say, I've had a lot of patients actually who were having back pain with squatting, especially front squatting, which is because of the lever arms and like the position of the bar. And they would literally like hip hinge to begin, and we would fix that. We would say like squat down, and it was significantly better. Not always asymptomatic, but much better. And I always kind of wondered like why that was such a prevalent thing, and I didn't realize that's actually also how I was taught to squat originally, back in the days of CrossFit before proper standardization and standards.
I'm fairly certain also in the CrossFit L1 they teach to maintain weight through the heels all the time. So there's actually a coach at our gym that would still teach heels, and he would actually let his toes come off the ground when he would squat, which would baffled me because he was coaching there for 2 years, and that's what he would teach everybody, and no other coach had ever called him out on it. But I don't think it's really relevant to this conversation. But the big things, again, I picked up from Jesse's squat were one big thing I see a lot of times is this kind of, you can see here, Alan, how do I draw things? Annotate, there we go, I got it. Right, the open hand. I can't. I'm not gonna draw. How do I get rid of that? I'm gonna stop doing this.
Yeah, I was mad at myself for doing that after I watched this video later. I'm like, why was I doing that? It was so embarrassing.
Do you normally do it?
I don't think so. I don't know. I've really been trying to get better about like closing my hands around it. I don't know. I genuinely have no idea whether or not I do it all the time.
Okay. So yeah, so I think Josh mentioned, Joshua, that when you grip that bar, we're going to engage the lats a little bit more. We're going to increase a little bit more midline stability and trunk stability. So by just grabbing onto that bar with a full grip, pulling that bar down onto her shoulders, she would have had a little bit more of that midline engagement to kind of get a little more stability throughout the entire torso. The one really nice thing I do want to point out, and I think you mentioned, how do I get rid of that? There we go. In your squat, you tend to have that little bit of, as you get tired, that hips first coming out of the hole. But the one really nice thing I noticed with your videos is, yes, there is a little bit of that, but what you see is as soon as you get past that, you have do a really good job of scooping your hips back forward underneath that bar, getting underneath that bar and then standing it right back up. So even though it is a little bit of what we call like that good morning squat, I would say it's minimal. And again, what percentage is pretty high percentage for you? Moderate, 165. I don't know. It's moderately heavy. I don't know. Anyway, but that was, yeah, I'm just calling her out nonstop. Her hands. Yeah,
So I just calculated it. It's just 75.
Okay, so I mean that's moderately heavy. But as you get fatigued, right, you're going to have those tendencies to come out. But again, what you do a really good job of is scooping your hips underneath that bar, getting back underneath and driving straight up. So that's why I like this video, and that's why I want to point it out the first one, because there are faults you're going to see in individuals. But what happens is, are they able to identify, can they correct it, and can they get back underneath and drive through it? Or are they just basically driving the hips all the way up to the air and then doing a good morning or a deadlift with the bar on your shoulders, which is never, ever a good thing.
Thank you for that.
Absolutely. So, hold on, I had a nice list. I think Zach's is the other one I wanted to take a look at. Close some of these. There we go. All right, so Zach is group 6. And same thing here, I'll play it straight through. Anterior view here. And 3 reps is pretty good there. And lateral view there. And then group 6, if you see anything, go ahead and just start calling it out, say it. Besides the fact that
before, we see a little bit of that lumbar reversal where he goes into that lumbar flexion at end range in the lateral view.
Beautiful. Anyone else impressed who's squatting with a really big wallet in his pocket?
I was impressed with it too.
Okay.
Pockets
Anything
ain't
else?
empty, cuz.
In the front video, we were debating. I thought I saw a left hip shift as I'm going down, but other people seem to think right, and I just can't see it.
So yeah, there's a
Go
bit of a little wibble wobble there, right? And so just for reference, I'm always trying to zero in my gaze on something in the background that looks semi-vertical, right? Yeah, if you have a perfectly red vertical line there, that also helps too. So that will help center out your gaze. I think like on rep 1, you maybe go left. Rep 2, I think you go kind of to the right and then to the left. So Guillermo will play it through again and kind of see what that looks like with that red line on there.
He's doing like keyboard squats.
Little zigzag action. If it's something that minor, personally, I don't fret about it too much. If I start to see a very consistent, more unidirectional shift that gets more apparent with heavier loading, then I'll start to be like, okay, so you know what I mean? Like this is a repeated pattern that's going on here. Let's try to figure out what's going on with the reason that could just be like, I was off balance in rep 2, you know what I mean? So at a sub maximal load for you, I wouldn't concern myself too much with that. I think I would dive into the like what Nick was pointing out in the lateral view, a little bit more of the lumbar spine position.
Good. Anything else, Group 6? Mitch, Alan, anything else you want to add to this one? No? Cool.
I thought overall it was obviously a pretty good looking squat. We talked about the wiggle, the right, left, and then debated, which direction it actually was. I would be curious to kind of see what his unilateral or rotational stability would be, because as he drops and then has to come back up, the hips have to reverse the rotation that it had. So I'd be curious to kind of see his rotational stability. Maybe it's something to take a look at as he gets heavier. I'm sure that gets worse and not better. But I thought overall, obviously, a good squat.
Agree with you there.
With the back squats, does the elbow positioning make a big difference? Like, should it be tucked under more, or?
So when we look at elbow positioning, especially with the back squat, ideally, at least from what I know, we want the elbows down tucked a little bit more, because again, we're looking to have that engagement through the shoulder. So if your elbows are flared up really high, you're gonna have a higher tendency to, one, dive your chest forward, but also to have more of like a loose positioning through your torso, through your trunk. So by pulling the elbows down and kind of in line with the torso, we're gonna have a little bit more of that really nice strong lat engagement, which is gonna help, again, increase some midline stability in there. So very rarely have I seen a very good heavy squatter with like a flared up winging elbow, and it's also just not comfortable to have your elbows that high, in my opinion. I don't know if people out there do that, but I can't imagine it's comfortable for anybody. Good, everyone agrees. Excellent. All right. So another one here that I thought was interesting was Emily's. So Emily, I don't see what group. Is anyone from Emily's group on here?
I'm in group
Emily's
3.
Here. Excellent. You're Emily.
Yeah.
Okay. So this one I saw in the comments, so I actually had to go back and check out your front squat because of what they were commenting on. And I actually pulled up your front squat video just for that purpose. So Emily, what for the most part, what were they saying about your squat? And what did you see about your squat?
So for me, I have that nice butt wink kind of happen at the bottom. And the other big comment was that I wasn't getting as low as I was clearly able to do from my front squat, because my front squat, I actually felt like I almost got too low, which caused some interesting movements, patterns, I thought. But then clearly a little bit different motion there. A little bit not as low getting with the back squat. I think I still see similar movements within the hips and then the spine as well.
And I think that was the biggest thing. As soon as they mentioned like, oh, like you're not getting anywhere near as deep as your front squat, I'm like, huh, I wonder why that is. And I pulled out both, and I saw that someone commented on your front squat, your feet look pretty wide. Maybe you should try and narrow your stance because it'll help with stability. So then I also pulled up a screen, or this is really creepy, but I pulled up a screenshot of you doing your front squat as well. And then I have so many open things right now. But I just looked to compare your stance from front squat to back squat. And I would argue that your previous front squat stance was probably pretty good for you. You seem to have some long legs, and that wider stance is probably going to make it more comfortable for you to sit down in between your hips and get down into that squat. Whereas with your back squat, now you have this load on your spine behind you. You want to still fight to keep your torso up, and now you're narrowing the movement or the space in your hips for you to sit down comfortably. I don't have a video of your anterior view, but I would say for you, this one here, that's weird, would probably have been a more comfortable position for you, and I would have played around with that a little bit more. You also have an empty barbell for the front squat, a more weight for the back squat, so having a little bit more load might have made it a little bit more uncomfortable if you're not like used to doing a lot of load and squatting with heavy load and things like that too. So I wouldn't mind seeing your back squat with that wider stance that you originally had for your front squat and seeing if that makes a big difference for what your squat depth looks like.
That makes sense to me. Thank you.
Absolutely.
And I think I kind of felt that actually when I was squatting a little bit, trying to keep that more narrow stance. I felt like I couldn't get as deep without feeling like I might fail, I guess would be maybe more
Yeah.
explanation too.
I mean, just watching the back squat, it just looks much more uncomfortable. Just like you're forcing yourself to try and get low. Whereas the front squat, I feel like you could just drive down there with no issue at all. So yeah, I would say go ahead and record yourself if you can with a wider stance with the back squat. Same weight, same everything else. See how much better it feels, or if it feels better, it looks better.
Perfect. Thanks.
Also appreciate that we structure these, we structured front squat week 1 and then back squat week 2 for that change in counterbalance, right? Like a front squat's very similar to that goblet squat, anterior low displacement, upright torso, a little bit easier for us to reach depth. When we move to the bar to the back rack position, some of this, I have to find stability intuitively. I have to like build my own counterbalance in the back squat and be comfortable reaching depth. So some of those changes are expected if we're not super comfortable with the back squat compared to the front squat.
The big reason why we also really emphasize the high bar back squat, because the lower that bar is for a low bar, it's going to shift that weight backwards more, which is going to make it harder to stay more in that upright torso. So by keeping in that high bar, moves that forward, that barbell slightly more forward, makes it a little bit easier to find that center for you to squat down into. Okay. Mitch or Alan, are any videos you want to check out?
Well, we saw butt wink and we saw that leg length discrepancy. Wasn't there?
There's, I think.
Was it Eric? No, it's not Eric's.
I can check my notes if you want.
No, it wouldn't be in there. I don't take notes. It might be Chad's lateral view. Yeah, pull up Chad lateral view group 2. Yeah, only because like the Dockers in the belt made for just like a good visual on the butt wink. And I just kind of want to hear from the room, because this is going to be the big one, right? Like the butt wink and the back squat, right? And what a lot of people walk away from is like being able to identify it, but still not really sure what the heck to do about it. So go ahead and let it play through and you'll be able to pick up on it. I know your eye is trained well enough. Guillermo.
I got it. Sorry.
Right. So right there at the bottom, the pants and the belt really help to emphasize like, oh, something shifted there. There was a change in pelvic position. I went into a posterior pelvic tilt, little lumbar reversal. The question I'm posing to the group, and points only awarded for those that mic up, 10,000 bonus points to the person who mics up first, where the points are made up and score, doesn't matter. What would you do? What's the first thing you would do? Say one thing you would do to try to tease out and correct the butt wink. Don't walk by and stare them down like guy in the background here.
I'd ask him if they can correct it. I'd ask them if they can feel it and say, can you change it first?
Awesome. Can you feel it, Kristen? And can you change it?
Like lots of times people don't know. And sometimes like same thing with lumbar spine range of motion. They don't go into full extension. Is that as far as you can go? Or you see them shift with a lumbar range of motion exam. Do you know you're doing that? Can you do something different?
Yeah.
And see if it changes.
Can you feel your back rounding? Can you make that not happen? What if they couldn't? Kristen gets 10,000 bonus points because she was quick on the trigger. It's like Jeopardy. Next question. What if they couldn't correct it? They could feel it happening, or they knew what you were talking about, but they couldn't correct it. What next?
Did you talk to him about his bracing strategies?
Beautiful. Are you breathing and bracing appropriately? Are you creating some stability around the midline? Awesome, Nick. 8,000 bonus points for going second. Nice work.
I can't really tell from the lateral, but kind of the perspective is perhaps that there's a little bit of that knee valgus collapse, like a little bit. That sometimes I find if you give a little bit of lateral knee tactile cueing.
Okay.
Yeah, there we go. Even if it isn't actually going in, just giving them that cue of like push out this way, and then suddenly like they engage. Yep. And honestly, I kind of wonder about the pants. They look like comfortable pants, but they might be kind of tight.
The exoskeleton. Yeah, totally. They're certainly not the most mobile, depending on how much stretch the Dockers say they come with. It's never quite like Alan's Paranobles. I've seen them sucker stretch. So I think you're on a good hypothesis there, Brian. What if I drive my knees out more, if I engage my glutes a bit more, that'll help stabilize the pelvis. And oftentimes in my simplistic brain, I think about like, if I drive my knees out more, I can sit between my legs, right? Versus sitting on top of my femurs, I can sit between my femurs. That makes sense, right? And so for some people, you will see them, even though on that anterior view, Guillermo, hit it, pause it at like right at the bottom of the squat if you can on the anterior view. You know, it looks like the knees are tracking in line with the toes, but this is something that there's some slight collapse there, right? I would still cue this even a little bit more lateral engagement, drive the knees out a little bit more, not so much that the big toe comes off the ground, keep the big toe pinned in, but I would engage the glutes a little bit more, maybe some tactile cueing in the outside of the knees and say, hey, push your knees out hard into my hands and see if that clears up the lumbar reversal. Okay, so let's say you made them aware to it. You asked them to fix it. They couldn't. You asked them about their bracing sequence. They were starting to pressurize and draw breath in the belly better. You checked out driving knees out laterally, and they're doing that, and they're still showing you a little bit about wing. What else do you do?
You could try to cue him to engage lats. Seems like his elbows are doing a little bit of a different thing, and it's maybe from the lateral view, it seems like that elbow is moving a little bit. So maybe cueing lats and trying to get him to be a little bit more upright.
Yep. And I'm going to pick a little bit further on that, Megan. How would you cue lats? Because disclaimer, if you say cue your lats, they are going to have no idea what that means.
Totally. I like to say, can you squeeze an orange between your armpits?
Fantastic. Yeah. Please, God, you guys do not say activate your lats more for me during your next squat, because they aren't going to change anything and they're going to look very confused and hope that they did it right. Right? Give them something actionable, an external cue like Megan just used of saying, hey, squeeze your armpits down tight like you're crunching an orange. Megan's taking a top-down approach to this butt wink, saying, hey, let's upregulate some thoracolumbar tension via the lats, right? And see if we can stiffen the back a little bit and keep that in line. I think that's a really, really good one. So we've got a lot of things on board here. What else? Maybe there's one more thing we can do to really tease out some butt wink. Anyone have one?
Would you do to like drop them down and do more of a tempo to see if they can control it with a little bit less weight?
Thank you so much, Anna. That's awesome. And there was a couple other people that were quick on it. So you had to be quick on the trigger there to get that one out. But yeah, I like the tempo work, right? Like just saying, hey, like going back to the original point, do you know you're doing it? And if not, let me stop you at the moment you start to do that and say, can you correct it? And then can I implement some of these cues? Pause right here because the butt wink is starting to happen. Guillermo's going to bring it to a point where we're good, and pause. And I'm going to hold my athlete right here. And I'm going to say, drive your knees out. I'm going to say, not activate the lats. I'm not going to say that. I'm going to say, squeeze some oranges in the armpits. I'm going to pull down on the barbell, bend the bar around your back, right? I'm going to say, drive your chest up hard and pull your butt towards your heels. I'm going to do all those things. And then when everything's checking out and the butt wink is gone, I'm going to say, all right, sink 1 inch lower. And if something start happening, I'll remind them of the knees again. Oh, don't forget about the chest being up. Squeeze them armpits tight. Let's get stiff, right? And seeing if we can just really hammer away and work out that butt wink. It takes work, but I guarantee you can make big, big improvements on someone's technique at their end range like that if you force them to pause and stick it out a bit longer. Questions on that, guys?
Can you just real quick recap all 4 of those things that you said?
Yeah, totally. The first one was like making the athlete aware to it, right? Like, and that could be via video, maybe a mirror they're having them squat in. I take video a lot, right? Are you aware of your low back rounding at the bottom of the squat? Maybe I put a hand on their low back so they can feel that tactile movement of their lumbar spine. Next was like, hey, are we breathing and bracing really well? Are we stabilizing the spine to permit some of that movement from happening, right? Then it was, am I collapsing in valgus? Can I upregulate some glute pelvic stability and really drive my knees out a little bit more aggressively and see if that helps up at that little bit of butt wink at the end range. And then it was some tempo work, really slowing the athlete down, giving him some time. Don't forget about the lats, squeezing the oranges and getting really stiff and tight through the upper back and the lumbar spine as well.
Thank you.
You bet. Great job, team. That's literally how it looks. Slow them down, make them aware to it, bring their attention to the area you want to fix, and give them a bunch of actionable cues. Your knees are falling in like Elvis right now. Drive your knees out like a cowboy, right? Crunch 2 oranges between your armpits really, really hard right now. Draw your butt forward as if reaching it for your heels, right? Pry your chest up and drive your upper back up into the barbell. All of those cues sound very actionable, very external in nature, very artistic, right? Like you can visualize and you can almost feel that cue, and you can feel what it would be like to do that in real time. And that's what they should sound like to your athletes.
I think showing people how they look, especially if they're actively lifting, they have a person in their mind that they wish their movements look like. They know in their mind whose squat they wish they had in the gym, and showing them like, this is what your squat looks like right now. And they'll know like, oh, that's what I look like. I thought I looked like so-and-so. And you're like, nope, not even close. Let's work on this, this, and this. Because they know what they want it to look like. Show them that it doesn't look like that.
Do we have a good app for analyzing videos on your phone? Yes. A couple of them. We like Coach's Eye, Huddle Technique.
Dartfish.
Dartfish?
Yep.
Never use that one. I always forget about that one. I like Coach's Eye a lot, mostly because I've used it and I'm familiar with it, and I like things that I'm familiar with.
You guys don't use Iron Path in this one, right? Mostly Advanced Concepts.
Yeah, we use Iron Path. The thing with Iron Path is that I'll put the video in Iron Path to get the bar path on it, and then I'll export it into Coach's Eye to actually do my analysis on it. I wish Coach's Eye would just give me a bar tracing option on it. Like, what the heck, guys? Like, get on with it.
I'm going to steal the screen for a second before we go, because I just want to show
Give it up.
Kelsey's progress here. So this was Kelsey last week, right? This is somebody that maybe they came to the clinic and they squatted like that. You'd think this person should maybe never squat in their life, right? You look at that and you go, oh God, like, you know what? I don't even know how to fix that. But just with coaching from last week to this week, some correctives to work on, some cueing, look at the back squat this week. So much better. And all we had to do was use our words, give some tactile cues, some squat to target drills, and look how much better we've made that squat in 1 week. And that's a really big point we make with athletes in the gym of come back next week. Hey, we made a little bit of progress on your back squat today. Come back next week. We're probably going to do some sort of back squat variation again. Like, you get better at it by working at it and being comfortable a little bit with the way the squat looks, knowing that with a little bit of work, it can become this squat. So when you see somebody in and you're not happy with their squat, you don't tell them you should never squat again in your life. You find a way to get them squatting and loaded in a way that you're comfortable with, and know that eventually they'll walk in looking like that. And that's how it's done.
Quick question, Alan.
Sure.
On that, how often are you rechecking doing that without the heels lifted, just to see if there's some good changes? Is that weekly? Is that every session? Is that every couple weeks? What's your all's take on that?
I'm measuring if it's an athlete that I know ankle dorsiflexion is a limitation. I've got an athlete right now that has a 15-degree difference. That's something we're measuring every visit to get that asterisk sign in the reassessment. I'm not expecting that person from Tuesday to Thursday to suddenly show me a deeper, more upright squat with better dorsiflexion. It just doesn't work that way. We know it's going to take weeks and weeks and weeks to change tissue length and get that mobility actually improved. We're measuring it in the treatment room to get that asterisk. And when we start to see, okay, today you're 3 degrees better than a couple weeks ago, a couple degrees is going to make a difference. Let's retest your squat, the same way we assessed it the first time. Let's assess it bare feet, or maybe your standard is a pair of shoes with a pair of VersaLifts. Then we're going to reassess it however we assessed it and see, did the depth improve? Does the control improve? That sort of thing. But you're not expecting, if it's truly a mobility thing and it needs a lot of time under tension, you're not expecting a miracle in a week. If it's motor control, for sure. But if it's true mobility, it's going to take a while.
That was a solid hour and 10 minutes right there. We just packed about as much in to that 70 minutes as I've ever seen. I think that's a solid place to call it for the night, because if we're not careful, we could run for another 2 hours on this topic. Let some of that digest, let it marinate for the week. Practice some of those bracing sequences, practice some of those motor control drills. You got a client coming into the clinic this week. I know that you're going to work on their squat. Use some of those cues, see how they work in real time, and shoot us back some feedback on the Facebook group. Always happy to jump into a little dialogue, a little discussion, a little Q&A on there. Next week, we transition into the other big hitter that you guys are here for, the deadlift. Let's be honest, you came for a couple really important things. You came to this course to figure out the squat and the deadlift. Everything else is just a cherry on top, but those are the big hitters. So that's why we lead right off the first 3 weeks with them. We're getting into the deadlift next week. Very, very excited for this. We're going to talk a lot about deadlift setup and execution, mainly hammering down on the conventional pull. If for some reason you can't comfortably get into a conventional pull deadlift setup and you feel better doing a squat stance or a sumo stance deadlift, for sure submit a video of that. We'd love to look at the differences, compare, contrast the two lifts, and we'll talk on them briefly. But a majority of our lifts are going to be in the conventional pull deadlift setup. This is a week where we're going to encourage you to load it a bit more. The first 2 weeks, if you weren't comfortable, motor control, back squat, empty bar, PVC stick, whatever. This week, we need some weight in your hand. We need to see you move a heavy bar off the ground. Heavy is relative to you, but I want to see you have to upregulate some stability. I want you to challenge your mechanics under load, and I want to see what a heavy deadlift relative to you looks like. Everyone can show me a perfect, well, not everyone, but most people can show us a perfect, very, very light deadlift. It's not until we start to get some load on the bar that things start to shift and change. And so let's be safe, but also challenge yourself in your deadlift positions and see what that looks like under some load. I maxed out my deadlift a week or two ago, so I'll be submitting those videos so that you can see what technique looked like at like 98% and then what technique looked like at 101%. And so you can see if you can compare and contrast those two videos from one another. I'll be out of isolation, won't be regulated the old Swift or deadlift. Didn't think about that. All I have is my broomstick. Guillermo, Alan, any other additional thoughts to go along with that?
Yeah. Speaking of isolation, we know a couple of you have texted me already that your gym is shutting down. So if you do have access to a gym, but you're not sure if you will for much longer, try and get in this week and film a couple lifts and work ahead a little bit. Otherwise, feel free to just Google a random deadlift if you no longer have access to equipment and break that analysis down for us based on what you see on random YouTube deadlift person. And we'll kind of keep that policy. Obviously, we want to see your own videos and you probably want to submit your own videos. But if you can't, we understand. As we get later into the course, we'll have dumbbell, kettlebell options as well. But just find an option, either yours or somebody else's video to get your homework in.
And I'm currently right now posting the Google Drive folder for all the deadlift videos as well as week 3 questions. So feel free to start jumping in on that as soon as you watch the lecture. Great job this past week. You guys are knocking it out of the park as far as getting your videos in and posting and commenting and doing everything right. Making my job extremely easy. So I appreciate that.
Yeah, this is a fantastic group of folks right here. Let's keep the momentum rolling.
All right, folks, have a great week. See you next Monday night.
See you all.